Welcome, everyone. Thanks so much for joining us today. I'm Angela Jones. The title of our webinar today is Optimising Pressure Injury Coding Through Interprofessional Collaboration to Improve Patient Outcomes. We all know that pressure injuries are a significant cause of harm in our health system, and Monash Partners has been leading some efforts over recent years to address and improve pressure injury management and most importantly, prevent pressure injuries across our network of health services. Just as a reminder for any of you that may not be familiar with us, we're a large-scale partnership of 12 health service research and teaching organisations established in 2011. Our purpose is to connect researchers, clinicians and the community to innovate for better health. And I'm delighted to be joined today by our two presenters, Dr. Victoria Team and Juliette Greskie. We begin by acknowledging the traditional custodians of the land on which we're meeting, and in a spirit of reconciliation, I pay my respects to elders past, present and emerging. I also extend that respect to any Aboriginal and Torres Strait Islander people joining us for this webinar. Wherever you are, we acknowledge and pay respect to our First Peoples. Just a little bit of an overview of what you can expect today. I'm going to hand over to Victoria in just a moment to provide a little bit of an overview for Monash Partners program of work in this area. And then we're delighted to have Juliette presenting at a much more detailed level. The idea of these webinars is to learn from each other, ask questions and discuss areas of mutual interest. To let you all know, we're audio and video recording the seminar today. We'll also save the chat and we'll send you a link to the seminar and a summary of the key points. Please share your questions in the Q&A, comments in the chat. We hope to have some time after Victoria's and Juliette's presentations to take some questions from you all. Just some information about how to contact us via our website and also on our social media handles. It's my great pleasure now to hand over to Dr. Victoria Team. Victoria is a Senior Research Fellow in the School of Nursing and Midwifery at Monash University, and it's been a great pleasure to work with her in recent years. She's a recipient of the prestigious Medical Research Future Fund Clinical Fellowship and a Chief Investigator on a Monash Partners work program around building capacity to optimise pressure injury prevention and surveillance across the Monash Partners healthcare services. She's been working very closely with the Monash Partners Health Services to enhance efforts to prevent pressure injuries and to strengthen surveillance, particularly in the area of capturing data and other capacity building components. And she's designed an online education program. So my great pleasure. Thank you, Victoria, for joining us, and over to you.
Thank you, Angela, and thank you everyone for attending this webinar. We hope you enjoy our presentation. Victoria, can you please move to the next slide? I will start from presenting our capacity building work at Monash Partners. We started our work in 2019 from establishing a steering committee for capacity building to optimize pressure injury surveillance and prevention. We have developed a capacity building framework, and this framework consisted of 5 main components, including collaboration, leadership, a complex capacity building research project, consumer involvement, and workforce development. We will talk more about workforce development today and also about our research project. Victoria, can you please move to the next slide? Yes, as part of our workforce development program, we have developed a training module, which is located at Monash Partners Education, Training and Events webpage. I have highlighted pressure injury. The slide is not clear enough, but on the webpage, you would be able to access this module. Can you please, yes. Thank you. Yes, this module was co-developed with Professor Carolina Weller from Monash University and with Monash Partners Pressure Injury Surveillance and Prevention Steering Committee. We would like to acknowledge all partnering organizations who have contributed to the development of this training module, and we would like to acknowledge WOMS Australia. I would like to also acknowledge our funders. The preparation of these materials was supported by the Australian Government Department of Health Medical Research Future Fund, and I want to pass my special thanks to Gillian Chamberlain, Amanda Boucher, and Monash Partners IT team who helped us to design this resource. Next slide, please, Victoria. I have included the web link if you would like to access this online module. This module would be of interest to clinicians who would like to improve their knowledge and practical skills in pressure injury prevention. It also includes a dedicated module for patients, carers, and families. And this module is available at no cost. We do not require any subscription. It can be accessed at any time. However, we would like to let you know that it doesn't replace the compulsory induction or professional development courses recommended by healthcare services. So far, we have developed 5 online modules, and we are currently developing 2 new modules which will be placed shortly. Next slide, please. So the available 5 modules include the introductory module, pressure injury prevention and care module, pressure injury prevention in COVID-19 patients with acute respiratory distress syndrome, patient engagement and pressure injury prevention, and our last module is resources for patients, carers, and families. Next slide, please. Now I would like to briefly introduce our complex capacity building research project. In phase 1, we aimed to map and compare existing pressure injury data across the Alfred Cabrini, Monash, and Peninsula Health. We have looked at incident reporting data, medical record coded data, pressure injury point prevalence study data, and we aimed to develop and pilot pressure injury data harmonization approach and to identify alignment with pressure injury assessment tools and coding definitions. In phase 2, we planned to identify barriers and enablers to pressure injury assessment documentation and coding. We have interviewed 32 clinical nurses across 4 Monash Partners hospitals, and we also interviewed 16 clinical coders. So as I have already mentioned, this study was a part of multi-component collaborative capacity building project. And one of the objectives was to elicit clinical coders' experiences of pressure injury coding with the focus on barriers and enablers. We were planning to conduct face-to-face interviews with coders, but because of COVID-19 and various restrictions by health services, we have conducted 16 phone interviews with clinical coders, sorry, it's written nurses, with clinical coders, and to analyze the interview data, we have employed the theoretical domains framework. Next slide, please. So discussing the barriers, there were a few barriers discussed by coders, and one of these barriers was the accuracy of documentation. So most of the coders highlighted the importance to ensure that the documentation of pressure injury is accurate, and we have calculated in all the interviews 43 times coders mentioned the importance of the accuracy. They said that information on pressure in the nurses' notes on pressure injury need to include a definitive pressure injury diagnosis, pressure injury stage, pressure injury location, and if pressure injury was detected on admission or acquired in a hospital, what type of assessment conducted, and what was the pressure injury care plan. Next slide, please. So the main facilitators discussed by coders were training prior to initiation of coding activity, continued education, audits, and feedback communication, particularly about how to handle specific complex cases and complex documentation. And many coders discussed interprofessional collaboration as the main facilitator. I have included a quote from one of the interviews. I think we have to work collaboratively together. We really do need to have a large voice because it impacts on data, it impacts on funding, it impacts on decision making across everywhere. We want to ultimately improve patient care. That's the end goal. So we need to really work together. Data is important. I think if there was one message, data is so important, so let's try and get it right. Next slide, please. And discussing the importance of interprofessional collaboration, many coders discussed the impact of COVID on interprofessional collaboration. And I just have included two quotes from the interviews. The manager has done education session with the consulting physicians here, but again, that was before COVID, which isn't really happened in the last year. But that is something that they talk about, how critical the accurate documentation is and a documented plan of care. And the second quote, so back pre-COVID days, the skin integrity nurse would come and they would talk to us about their process, and we would talk to them about our process as well, to try and bridge that gap between understanding the care delivery process and the documentation process, and then the coding process. So, and linking those three areas together. Next slide, please. And we have recently published an article, and I have included the title and the DOI in case you would like to read the full text, which is accessible to everyone, as the article was published open access. And in order to improve interprofessional collaboration, we have invited one of our experienced coders from a Monash Partners Health Service, Juliette Parsons, who will present and discuss how important the interprofessional collaboration, the main aspects of coding, and some other major aspects that would help nurses to improve documenting pressure injury. Thank you.
Thanks so much, Victoria, for setting the scene for our webinar today and for our presentation by Juliette. It's now my great pleasure to introduce to you Juliette Greskie. Juliette's a graduate of La Trobe University with a Bachelor in Health Information Management, and she's been working most recently as a coder at the Monash Medical Centre, and Monash Health is one of the lead health service partners of Monash Partners. Juliette has enormous experience in this area, having worked for about 25 years with a focus on the improvement of coding education and auditing, and she's worked across both public and private sectors nationally and internationally. As I mentioned, she's currently a coding advisor and coding audit program coordinator at Monash Health, in addition to providing services externally as well. Welcome, Juliette. We're delighted to have you, and thanks so much for supporting our webinar today. Over to you.
Thanks for having me. I'll just share my screen. This one up and running. So today I'll be talking about pressure injuries reporting and coding. The key topics are the impact of national and state coding standards and advice, the accuracy of pressure injury reporting and how it affects coding, and the role of interprofessional collaboration with clinicians in improving the quality of coding. Just briefly, for those who haven't been exposed to clinical coding before, the International Statistical Classification of Diseases and Related Health Problems 10th Revision Australian Modification, or ICD-10-AM, is used to classify diseases, injuries and related health problems. The alphabetic index is intended to include most of the diagnostic terms currently in use. The Australian Classification of Health Interventions, or ACHI, is used to classify surgeries, therapies and health interventions. And both the disease and intervention classifications have an index and tabular list that are used together. After locating a code in the index, we then refer to that code in the tabular list for important instructions, such as includes and excludes notes. These instructions provide guidance on the use of additional codes, sequencing and exclusion notes, which indicate rules regarding code application. ICD-10-AM, ACHI and ACS is used for all admitted episodes of care, including acute, newborn, mental health, subacute and non-acute care. And so that's just a picture of the 4 books that we use. And we also use that in conjunction. Whilst using both the disease and intervention classifications, we also have to refer to the Australian Coding Standards, or the ACS, that were developed with the objective of providing sound classification convention guidelines in accordance with ICD-10-AM and ACHI. For the purpose of today's presentation, I'll be going into detail of the 4 listed ACS there. This is just a really brief history in the development of pressure injury codes and code application. A particular Victorian coding standard was brought in 2017 called VIC-002, and this resulted in a lot of confusion as to what conditions could and couldn't be coded as additional diagnoses. Since then, VIC-002 has been integrated with ACS 002 nationally, and much of the confusion has abated with the simplification of the standard, along with clarification of various aspects by both the national and state coding bodies. This history needs to be kept in mind when conducting any research of pressure injuries, along with how changes to coding standards and advice may also affect statistical information gathered from coded data. Given the frequency of pressure injury coding, the coding will have changed over the years depending on what advice was current at the time. So as we discussed when starting this project during the interviews, there will have been a decrease in pressure injury coding, followed by a slow, maybe steady increase in pressure injury coding due to the change in national and state coding standards. So here is the current pressure injury classification, where you can see we assign the code by stage and then add a further code to specify the site of the pressure injury. Synonymous terminologies include bed sore, decubitus ulcer, plaster ulcer, and pressure ulcer. So the first standard I'm talking about, ACS 001, generally it's pretty clear if a patient has been admitted for care of pressure injury on its own or in addition to other conditions meeting the principal diagnosis standard. Clinicians should keep in mind that if a patient presents with more than one condition, then generally the first condition documented on the discharge summary will be deemed the principal diagnosis, and this will drive the DRG and funding for that episode of care. Then we move on to ACS 002, additional diagnoses. Whether or not a pressure injury can be coded as an additional diagnosis is where it has been a bit less clear in the past, where changes to coding of additional diagnoses impact on the application of pressure injury codes. Additional diagnoses have to meet certain criteria in order for a code to be applied. Therapeutic treatment would include, but are not limited to, commencement of antibiotics for infected pressure ulcers or debridement by a podiatrist. The last point here, increased clinical care, is generally the point that has caused contention, requiring multiple queries to state national bodies in order for it to be clarified. Conditions which are managed through general nursing care do not meet criteria for clinical significance outlined in ACS 0002. Therefore, if the nurse orders a pressure mattress, a device, or dresses a pressure injury, this would be considered routine nursing care and does not justify the coding of pressure injury. Preventative care does not justify coding of a condition. Therefore, if the management of a reddened area of skin to prevent the development of a pressure injury is undertaken, this would not justify the coding of a pressure injury. Here are some pressure injury specific examples of increased clinical care. So commencement of a wound chart, referral to a wound specialist with a documented plan of care, documentation or discussion with a second nurse or other health professional regarding the management of the pressure injury, or application of back dressings or devices not previously required. In this example, the pressure injury is coded because there is documentation of the condition, assessment of the pressure injury, and a documented plan of care to support the management of the pressure injury. It should be noted that a documented plan may be in the progress notes or on a wound management chart. A wound specialist or general nurse may formulate and document a plan to manage the pressure injury. In this example, the small pressure area is not coded because no care plan for the condition is documented. The care provided for the pressure area was a routine intervention. Pressure injury prophylaxis and prevention are considered routine care and do not indicate clinical significance of a pressure injury. Moving on to ACS 1221 pressure injury, the standard requires you to assign various pressure injury codes to capture both the severity and the site of pressure injuries. The intent of ACS 1221 pressure injury classification point 1 is that the same code is not assigned more than once. This may result in variations between what is reported by clinical staff and the coded data. It should be noted that there are also additional guidelines for coding pressure ulcers due to diabetic foot, which I won't go into today. Basically, this standard is that the assignment of pressure injuries, we don't assign the same code more than once. So on the next 4 slides, we'll show you a number of examples that are listed within ACS 1221. It is assumed that the pressure injuries in these examples all meet the criteria for coding, even though it's not documented within the example. So an elderly patient with a stage 2 pressure injury on the left heel and a stage 3 pressure injury on the right heel. These are separate sites, so both can be coded. A patient with a stage 1 pressure injury on the left heel and a stage 1 pressure indicated on the right heel, we can only code that once. We have a separate standard about double coding, that we're not allowed to apply the same code more than once. So once again, these are just indications showing you where we have to take into account the stage and the site of each pressure injury. We need to have the term unstageable documented as such. We're not allowed to if something does not have unstageable documented, we're not allowed to use that code. Example 7 shows the evolution of a pressure injury from stage 2 to stage 3. Therefore, we only code the highest stage. As well as example 8, where a pressure injury where it's documented between stages, where they're 1, 2 or 2, 3, we go with the highest stage. Moving on to some actual documentation examples. Hopefully you can see this okay. In this example, increased clinical care criteria are met. We have a clinical assessment, we have a diagnosis and a documented plan of care. Therefore, for this example, we are able to apply pressure injury code for stage 2 lower back. This example also meets criteria for coding with documentation of a wound management chart. We have a diagnosis and we have an assessment and we have a plan of care in the wound management chart that's been completed. In this case, we were able to apply 2 pressure injury codes, given the documentation of the stage 3 and the suspected deep tissue injury. These pressure injuries are on bilateral heels, which means we can code both. When coding diagnoses, we also have to apply prefixing to identify if conditions were or weren't present on admission. In Victoria, we use a P for present on admission and C for arising during the admission as a complication. This is becoming increasingly important with the introduction of HACs or hospital-acquired complications on July 1, which I will be discussing shortly. In the example here from ACS 0048, the stage 2 pressure injury developed during the admission. Therefore, this is classified as a condition onset flag 1 or C in Victoria. It should be mentioned that if the documentation specified that these pressure injuries were bilateral, then 2 codes would have been applied, one prefixed with a P and the other with a C. It should also be mentioned that if a pressure injury is present on admission and progresses from one stage up to a higher stage, then only the higher stage is coded and would be prefixed with a P, given that this was present on admission. So now I'll move on to showing you some of the relevant coding advice. Here are some examples of current state coding advice that have to be kept in mind when coding pressure injuries. This is in addition to the Australian coding standards. We have VIC 3101, which gives us clarification when coding pressure injury of more than one site. We have VIC 3129, which is pressure injury secondary to thromboembolism deterrent stockings, or your TEDs. We also have VIC 3173, which gives us clarification on coding pressure injury to axilla, and VIC 3589, which clarified that wound management charts did constitute a plan of care, which then allowed us to use them to determine clinical significance when coding pressure injuries. So, in regards to where our coding queries are sent and where our coding advice is received from, we have both state and national coding advisory committees. So our first port of call would be to send a coding query off to the Victorian Coding Committee, and then they generally would, if they are unable to answer the query or they feel that it's a national concern, they would then send it off to the National Coding Advisory Committee. Moving on to funding implications of pressure injury coded, it should be noted that although pressure injuries can hold DCL values, which are diagnosis complexity level values in certain DRGs or diagnosis related groups, that can lead to the optimisation of a DRG and increased funding, some pressure injuries are also classified as HACs or hospital acquired complications and can therefore incur funding penalties in certain circumstances. A hospital-acquired complication, or HAC, refers to a complication for which clinical risk mitigation strategies may reduce, but not necessarily eliminate, the risk of that complication occurring. The HACs list offers 16 agreed high-priority complications which clinicians, managers, and others can work together to address and improve patient care. If a pressure injury is determined as having been a hospital-acquired and prefixed with a C or a condition onset flag 1, then it could potentially be a HAC. The adjustment is the percentage of funding reduction of the base National Weighted Activity Unit, or NWOW, for any episode with an identified HAC of 1 pressure injury. These percentages are adjusted each financial year. These adjustments also take into account the complexity profile of each episode, as they are modified for each complexity group, low, moderate, or high, to ensure an equitable adjustment to public hospitals relative to their patient risk profile. Keep in mind that pressure injuries acquired in previous hospital admissions will not incur HAC penalties for future admissions. This is why it's important not only to document if the pressure injury is hospital acquired, but whether or not it was present on admission. I've listed next financial year's adjustment figures here. So as of July 1, when HAC funding will come into play across the state, any patient who has a HAC or a pressure injury where it's a low complexity group will have a funding reduction of 10.9%. Moderate is a reduction of 6.6%, with a high complexity patient having a reduction of 5.8% of the base funding. Only the pressure injuries listed above could potentially be classified as a HAC, stage 3, stage 4, unspecified, unstageable, and suspected deep tissue. From the code finder example listed below to the left, you can see that the HAC is clearly identified by the red square with the HA. The National Activity-Based Funding Estimate reimbursement shows the HAC group. This example is a financial year 21-22 data, shows that pressure injury with the relevant complexity group and HAC adjustment, that in this case is 9.8% of the base NWOW. So this patient will have a 9.8% reduction in their funding. I'm not sure how many of you may have seen documentation queries that many clinical coders write to obtain specificity, clarification, or further information from clinicians. It should be kept in mind that many coders will not initiate documentation queries regarding a pressure injury, whether querying to apply the code or for a code site or severity specification, if it does not result in optimisation of funding. This comes down to the fact that resources such as coders' time and accessibility of clinicians are limited. This can include when the pressure injury is being coded as either a principal diagnosis or additional diagnosis. This will reduce the quality of pressure injury coding, but is often an unavoidable circumstance. But it also highlights the importance of accurate, specified documentation so that coders have all the information required at the time of coding without necessitating a potential documentation query. The best time to ensure accuracy of pressure injury coding is from the start, when training coders who are new to the profession or your health service. Show them the best spot to find documentation and specification. Ensure that they are up to date with the standards and relevant coding advice. Teach them when and how to write a documentation query. Reminding coders that clinical knowledge needs to be backed up by documentation, not just interpreting or diagnosing incomplete documentation or images into codes. Not relying on codes from memory. Check the tabular, excludes notes, check the code once you've entered it to ensure you have entered the correct stage and site. Ensuring that all coders remain up to date with changes to codes, rules, conventions, and advice is vital. Coding is a continuously changing and evolving profession, sometimes to its own detriment. External audits are often completed by the Department of Human Services or health funds within the private sector. Some health services also engage external auditing services for funding optimisation or as a quality measure. Make sure you review all data sources so that you get a complete picture of how your health service is tracking in relation to pressure injury coding. Using audits are also a good way to ensure that recent changes to standards or advice are being adhered to and implemented by coders. Ensuring other health professionals, such as wound nurses, are aware of any changes is vital in making sure that the right documentation is available to the coding staff. Creating relationships with the relevant parties means that this information can be passed on within efficient timeframes of any changes. Using the correct terminology, such as pressure injury, area, ulcer, or decubitus ulcer, as opposed to terms like blister, erythema, wound, or skin lesion. Ensuring that the right documentation is present and easily identifiable from the beginning will help ensure accuracy and decrease dependence on the documentation and coding queries. Introduction of electronic medical records or EMRs across various health services has led to confusion and where to find documentation or further specification of documentation. It is important that coding staff are considered and consulted at the time of development or updates of both paper forms and electronic systems, as often the end user is not included and their requirements are overlooked. As mentioned on the previous slide, often various units or specialists keep databases of patients or complete risk management systems for various events such as hospital-acquired conditions. Using the information from these databases can be beneficial in ensuring some missed cases of pressure injury are picked up. Including coding staff and advisors or educators in nursing education sessions and vice versa can be beneficial to both departments when it comes to information sharing. Just finally, complete documentation assists accurate coding from the beginning. It saves time and it results in accurate funding. I'd like to thank you for having me today to be able to present on coding, and we'll open the floor up for any questions.
Juliette, thank you so much for that really terrific update. This is obviously a really highly complex work area. It illuminated to me the complexity of going through medical records and trying to, I guess you're putting together a picture, aren't you, and trying to capture the key elements, and the work that you do is so dependent on, it brings home the importance of documentation by bedside clinicians.
That's the aim, is to be able to tell the entire story of the patient's admission in code.
Victoria, just highlight to everybody who's online, if people have got questions or comments for Juliette or Victoria, just to pop them into the chat. I guess it's so challenging, isn't it, often for bedside clinicians? There's the demands of providing care, and then I think as a nurse myself, I know that the requirements for documentation just seem to steadily increase the whole time, and sometimes you feel, I think, a little torn between meeting your obligations to provide quality care, but then also being cognizant of the importance of documentation. And I think that's sometimes a real tension. Do you feel that with the introduction of electronic medical records, I note some of your comments, Juliette, around the importance of the development of those systems with everybody, coders along with the clinical perspective. How has EMR impacted from your perspective on the documentation of clinical conditions like pressure injuries?
Well, obviously it depends on which package EMR the health service has. We, one that I work with, we no longer get comprehensive nursing notes like we used to get. You also miss out on a lot of formatting that you could have had within paper record when things were handwritten. We miss out on maybe some of the pictures that clinicians would have drawn, citing pressure injuries and indicating which pressure injury was which stage. So having hybrid systems where we could have scanned charts helped, but and obviously, and I still work at another place where we do have a scanned medical record, but it is handwritten. So EMR brought up a whole lot of complexities in regards to, and where to find the documentation as well. It's all a little bit more difficult, I feel.
Yeah, interesting, because you're right, there would always be the nursing report, which sometimes if there wasn't a chart, that might capture some of these really important elements, and not having that as a reference point is a really significant change.
Yes, yeah. I mean, I do prefer old school handwritten notes. It's a lot easier to understand formatting from clinicians if they were linking conditions and things like that. And also the nursing notes that we used to get were just invaluable. I mean, we read an entire admission from the registration form through to the medication charts. We read every page. And moving on to EMR was a massive challenge for us, trying to identify where to get the correct documentation, also to work out when documentation was updated or if it hadn't been updated. Some people would go with updated documentation, others wouldn't. There's a lot of copy pasting as well, which EMR lends greatly to, just copying and pasting a whole chunk of documentation, which may not necessarily have been the updated version.
Interesting. I'm going to just over to Victoria team. For Victoria, any comments or questions for Juliette?
Yes, I have no questions for Juliette, but I would like to thank you for her presentation and what she has told about the introduced electronic medical record. All the issues were discussed by other coders from other health services as well, particularly accessing documentation, where to find the particular part, and particularly the transition to EMR was difficult. Also, many coders said that there were people who would come and support them during initial periods. Then they were supposed to start doing this themselves, so it became really difficult. And in relation to pictures, other coders also acknowledged that, so previously nurses were able to draw pictures, and particularly if the patient had multiple pressure injuries, it was just, and on different limbs and in different locations. So it was so clear to have a chart to have a look at this picture, which they were unable to longer find in EMR.
Yeah.
And also there were concerns. So if the nurses use inappropriate terminology, for example, wound in terms of injury or blister, again, so EMR would not even capture this word and to bring this pressure injury to coders. Yes, so all these issues were discussed.
Yeah, we would have to, if we had documentation that we thought implied a pressure injury, we would then send a documentation query to the relevant people. There's a lot of, with coding, that you do have to look for the documentation and be able to back up the documentation. There's also a lot of reading between the lines for us as to when a condition may be implied, but the actual words we need are not there. So that's where a lot of our documentation queries stem from, is clarification of the documentation and the various components. Yeah.
Thank you, Juliette. And we have one question to you. Thank you, Juliette. You discussed we have a state and national coding advisory. Is coding the same now for each state in Australia? Thank you.
Yes, so Australia has moved to, the coding has always been the same across each state. It's the funding model that was not the same. We have now moved to a national funding, national-based funding. So every state will now be coded and funded the same. There may be some minor intricacies where different states have different price values, but we now have a national funding. We are now national-based funding, and the coding should be the same across all states, given that the funding is now the same.
And there was a comment, the difference between paper and electronic is that the electronic allows for more granular documentation. I agree, depending on the EMR, it can be fragmented, but it was on paper as well with wound charts, progress notes, and care plan.
Yes, agree. There are a lot of benefits to electronic medical records in relation to timeliness of documentation and things like that. And obviously, it's not something that we're going to go back from, but I guess there are going to be pros and cons for all end users.
Juliette, I'm wondering if there was, what would be the kind of top three things? No doubt we've got some clinicians online today joining us, a variety of people attending. What's top of mind for you in terms of your advice to anybody who's working in a clinical role and looking after patients with pressure injuries? What are the most important things for them to remember?
So I guess sighting, staging, and treatment are one of the big things that I didn't mention, but debridement. If any debridement occurs, particularly Sharp's debridement or excisional debridement, that can be a massive changer as far as DRGs go. Non-excisional debridement doesn't really do a lot for us, but yeah, clear documentation of when things are excisionally debride, particularly, and also referrals to different clinicians for your pressure injuries. If you're calling in the wound nurse or the stoma nurse to look at it, and clearly document if a vac dressing has been applied. Sometimes it's getting a little bit more difficult given the different terminologies. You'll see Prevena, you'll see other names that may not necessarily jump out at us straight away in relation to vac dressings. Clearly that's an evolving field with different technologies and names coming up, but just good old vac dressing would jump out at us as far as being able to then code the condition, and also clearly documenting if the pressure injury is evolving into a higher stage. Any infections or bugs, if there is any swabs done, wound swabs of the pressure injuries, if there's any infection there, that will also impact how we code it, and also we would be looking for resistance to particular antibiotics. If there is an infection in the wound. That's the kind of depth we go to, is we'll not only look for if there's a pressure injury, we will then look for if it's infected, we'll look for if it's debrided, and we'll look for if any infection has any resistance to antibiotics, which are all the kinds of things we have to code.
Almost like a forensic exercise, isn't it? Looking for evidence.
It is. That's what we are. Yeah, it's real detective work as far as reading between the lines, and then we see a condition documented. We have to deep dive right down into that to see where can we go with this. Yeah. we need to give a complete story, but I don't think a lot of people realise how accurate and complete it needs to be.
Fascinating. Let's see if we've got any more final comments. Just pop them into the chat. Victoria, anything from you to wrap up today?
Well, so I wanted to ask Juliette if she has provided suggestions for clinicians. I think it would be nice if she will provide 3 main points or suggestions for clinical coders.
Clinical coders. Let me think. Going back. So obviously it's knowing where you're getting your documentation from. Be very clear on where you're getting your documentation from. Be very clear on your state coding advice. And being very clear on your applying your ACS 0002 and whether or not the pressure injury meets clinical significance. That's where if you ran any reports based on codes for pressure injuries, you would have noticed that in 2017 in Victoria, there would have been a steep decline in the coding of pressure injuries while we were all trying to work out what was clinically significant. I don't think that it will ever climb up. The pressure injury coding will never climb up as high as it was pre-2017. But clarification, hopefully we will be capturing all clinically significant pressure injuries, and also keeping in mind the onset of when the pressure injury occurred. With HACS, with the introduction of HACS in July 1 and funding ramifications from hospital-acquired complications, I think that the collaboration between coders and the clinicians, because HACS are going to be obviously brought up everywhere. It's not a coding issue, it's a patient care issue. So obviously our information will be getting used in conjunction with the documentation on risk bands and things like that, whatever reporting systems people have, that we're going to have to collaborate to share our information and make sure that things are being accurately coded and represented, and also help with the risk mitigation on the ward.
Thank you.
Juliette, there's a question that's just come through in the chat. Your view about why the term unspecified is still used?
Because sometimes we don't get documentation. I can tell you that we will, certain sites, I mean, if there's any coders on board here, I don't think it's going to be a massive secret that you should probably audit every single pressure injury that is coded as unspecified. Any coders or managers who are watching, please make sure that you're auditing any pressure injury coded as unspecified, because there really should be no cause for that. It should be, we would code it as unspecified if it didn't have any funding implications, but given that it's now going to be a HAC, if it occurred on the ward within the episode of care and it's unspecified, that should be getting queried and clarified by the coder. So there should be audits based on that.
Thanks, Juliette, for that clarification. I'd just like to take a moment to say, express my thanks to both Juliette and Victoria for supporting our event today. I think, Juliette, your presentation has highlighted how critical documentation is in terms of capturing an accurate narrative of the patient's journey through our health system, and how important that is from a number of standpoints, risk management, care, and also reimbursement. So I've learned a lot from your presentation today. Thank you so much. Thanks, Victoria, for setting the scene. Everyone will send you out a link to the recording and a brief summary, and please watch out for future events. And thank you so much to everyone for attending today.